In addition to suicide prevention screening at Parkland Health and Hospital System, social workers have provided additional benefit across the inpatient, emergency department, and outpatient settings. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hedderly, senior writer for AHA. In this episode, Elisa Arispacochaga, vice president of AHA's Physician Alliance, speaks with Jenny Esparza, behavioral health social work manager at Parkland Health and Hospital System, and Diann Francis, social work manager at Parkland Health and Hospital System.
Welcome to another podcast in the AHA's ongoing series where we focus on important issues facing our clinical leaders. I'm Elisa Arispacochaga, Vice President of the AHA's Physician Alliance, and today I'm really pleased to be joined by Jenny Esparza, Behavioral Health Social Work Manager, and Diann Francis, Social Work Manager, both at Parkland Health and Hospital System. And today we're talking about reducing suicide across the inpatient, emergency, and outpatient settings. To get us started, I'll start with you, Jenny. Tell me a little bit about yourself and your role at Parkland, and then we'll go to Diann.
I'm currently the social work manager over the social work component in the psychiatric emergency department and the extended observation unit. That also comprises, the psychiatric emergency department includes the medical emergency department area as well. And I've been with the organization Parkland for almost 5 years.
And Diann?
I am the social work manager. I work primarily in the primary care clinics. Parkland has a network of primary care clinics where we actually provide services to patients of all ages. And my primary role is providing management and leadership for the social workers in those clinics. And I've been with Parkland for 27 years.
So as this is part of a series of conversations we've had with your colleagues at Parkland, we've heard a bit about the value of motivational interviewing in suicide screenings. And Jenny, let's start with you. Can you tell me a little bit about how adding that social work component and your role as a social worker has impacted that work?
It was originally based on the design for the universal suicide screening, and especially needed as part of the secondary screening that were going to be assigned to the social workers. During this time frame, they'll probably go more detailed in the webinar. During this time frame, we actually had an influx of psychiatric needs patients that were identified to be voluntary and also identified based on the screening as high risk, but we had a shortage of providers that be able to respond in a timely manner. So it was a complex situation where we took the skill set needed as part of the design for motivational interviewing. They assessed that staff needed to be trained in for social workers. We took that component, added it to not only address the results of the universal screening for the patients identified as high risk, but also to manage the patients that were considered voluntary and just needed additional resources and have a complete psychosocial assessment. And it resulting that we push our staff through the training, not only increasing their competence, but increasing the efficiency in the manner they were able to assess patients for different variables of risk. And it really made us an asset, especially in a demanded need where we needed more providers and there weren't enough available to see all patients during that time frame.
And Diann, from the primary care space, how did you see the addition of social work to the team affecting the work?
Right. I would just like to add to that. Basically, on the primary care side, prior to doing the suicide screenings and the suicide risk assessments, patient came in. They may arbitrarily be referred to social work. They could be referred to a behavioral health team member, psychology, or mental health counselor. So once we were able to put the process in place, it really just streamlined everything and made it more efficient. It also gave social workers an opportunity to enhance their overall skills in order to deal with the patients and to be able to really assess and determine those who really needed that next level of care versus patient comes in, patient says, I'll have thoughts of hurting myself, and it'd be more of an automatic send to the psych ED. So again, we could do a better job on the primary care side to assess and really, send those to the psych ED who actually needed that next level of care. Sometimes it may be that the patient needs to follow up with community behavioral health provider, even some follow-up with their primary care physician. So overall, it just made the whole process in terms of assessing someone with thoughts of hurting themselves more efficient and then, again, more effective in terms of getting the patient to where that patient really needed to be.
Correct. I would agree with that.
Sounds like it's also a lot more patient-centered in making sure they get the right care that they need when they need it.
Right.
Yeah, especially, yeah.
So you've implemented this approach across a variety of behavioral health treatment centers. And again, we're going to start with Jenny on telling me a little bit about how it's impacted the settings. Start with the inpatient psychiatric treatment setting.
We extended the motivational interviewing to all, the social workers from all psych areas, regardless of where they were assigned. So what we noticed that in our inpatient setting, social workers do conduct, groups. They do work with, as part of the whole interdisciplinary team, to assist with, discharge planning, things of that nature. But they're also using it on their individually in the way that they assess the patient themselves. So it was like an added benefit, like Ms. Diann is saying. Not only are they able to more efficiently screen and vet for any items that weren't really addressed, or resources or needs that they need, and that way we could kind of fill in the gaps and provide a form of wraparound services. So it's really more in tune to assess and vet for information that we possibly could have missed, or to ensure that we're providing the best patient care that's needed at that time.
And I know you said you've also used it in the emergency room to great effect.
So in the emergency room, it's going to be more in detail with the webinar, but we were essentially assigned to do the secondary suicide screening component for social workers. So the initial universal screening component is done by the ER nurses when they enter the ER. So the social workers took that information, because we have, based on a point system, so that's how they feed into a particular track board, so it's assigned to our service line. We took that information, paired with motivational interviewing, identified a lot of the components of completing, psychosocial screening. In addition to, a safety plan intervention, we do a lot of items that are evidence-based, based on the design. It kind of made the social workers be more efficient. We call them sitters here. When people are identified as high risk or addiction themselves, we kind of have a sitter sit with them. So we're able to assist the ER and decreasing the amount of those sitters, but also being efficient that a social worker in the ER can actually go out, complete the psychosocial assessment based on both voluntary and high risk, complete their assessment within 30 to 40 minutes. That usually includes documentation time, as well as provide the necessary resources. Since we have a lot of items in-house or a good community partnership, that we're able to provide, ensure they leave the ER for this component, ensure that they leave with an appointment if it's applicable, or the required resources they kind of need, case by case, based on what the patient's been identified as far as a risk or an essential need that they have.
It sounds like it's making it much more efficient. Diann, tell me a little bit about how this is being used in the primary care setting.
So basically, when the patient comes in to see the primary care physician, all patients are screened. The nurses do that initial screening, and based on the score, and then they're referred to social work for further assessment. So one of the things that if a patient came in and just said, I have these thoughts, every patient is screened every time. We actually screen from ages 13 and up. So everyone is screened each time, and based on the score, again, that patient is referred to social worker for further assessment. I think the other piece, and Jenny kind of talked about that, is that because we're now assessing on a more consistent basis, we can get the patient connected to other resources that may be appropriate, which may not necessarily be at the level of going to the psych ED. The other piece is, because we are in primary care, the social workers have opportunities to follow up with the patients after they've done that assessment. So even if the patient is assessed in primary care and they are sent to Parkland to the psych ED, the social worker can follow up because we have the electronic medical record, and then follow with the patient to see if the patient kept whatever appointments that might have been scheduled for the patient. So again, it's a kind of a continuum.
Care really wraps around the patient and their needs.
Mm-hmm.
Jenny, how is this work that you've done? I mean, it's clearly made your team much more efficient, but how has it really impacted your patients and then the broader clinical team that you work with every day?
I think it really gave an emphasis of why social workers are greatly needed. Definitely boosted our, clinical skill set, in which it really a lot of the other disciplines do respect our profession. We really work alongside other disciplines really closely, and they see the value of our contribution. For instance, in the main ER, one social worker assigned both day and night was able to, for fiscal year 2019, was able to see 2,426 patients. Out of those identified of those 2,400, 512 were considered high risk. And the amount that actually required, we have the ability to, pass along to different service areas or ask for the psychiatric provider to come out and assess as well. If we need that, they need more, medication management, or they need more time in one of the PED or the EOU. In fiscal year 2019, only 6 of those were made that they felt that would require additional time. So it really allowed a lot of flexibility for us to all come together. We do have a saying here in Parkland that every patient's all of our patients. And it really comes down to mental health. There's a big stigma where nobody really wants to kind of address the need, and it really gave respect for other disciplines to kind of respect our discipline and our service area and kind of work together and do what is best for the patient. And our staff appreciates it, the providers, things of that nature.
Diann, how about from your perspective, how has it impacted your patients and then the team that you work with?
Well, one of the things I think pretty similar to what Jenny has already said is that with the team, we gained a lot of trust, enhanced the overall value. Initially, when we first started and when this was first being discussed, there was a thought that patients who had those suicidal concerns should primarily go to a behavioral health provider, psychologist or a mental health counselor. In the COPC clinics at that particular time, the staffing was not as robust as it is now in terms of behavioral health providers. You may have had a behavioral health provider at a clinic maybe 2 to 3 days a week, whereas social workers were present on site each and every day. So one of the things it helped us to do is to expand our overall scope of practice and really work more toward the top of our license. Oftentimes with social workers, sometimes we're seen as, providing only those kind of concrete services. And so to be able to say, there are some other things that we can do, and that the team can see that, and they can see that, oh, wow, the social worker is a great resource. And we've always been embedded within the clinical team, but now it's social workers to go to for anything that's suicide-related if a patient expresses those concerns.
Jenny, going back to you, what are some of the lessons you learned as you set this process up, and maybe some advice you'd give to our listeners who might want to do this work in their own organization?
It really does require buy-in. I think education is important for all. From our aspect where I was, it was a lot of education from not only the employees to understand and leadership groups to understand what we are doing, but try to understand the overall picture. And then really providing, once we started releasing certain data that was coming out, having the viewpoint you do matter. Look at how much the numbers are kind of coming out. It allows for a lot more buy-in. And once we had the buy-in, we greatly had the support from a lot of the senior leadership, and that came essential, especially when we're trying to utilize certain space for interviews. They've become really supportive, and as far as education, our program directors even allowing us to, we actually have changed the initial motivational interview class, where we actually have revamped it into 2 different phases, where now it's going to incorporate suicidal risk and SUD component added to the secondary phase. So it's a lot of room for growth. Definitely stick with it and be open to change and being flexible based on the original design. For instance, the secondary screening, we initially thought we can actually clear people in less than 15 minutes. That ended up not being the case. It ended up being more towards 30. So all of us had to kind of be flexible, what it meant to meet certain metrics. But once they had the foundational knowledge of we're doing more than just asking the secondary screening. We're actually completing a psychosocial assessment. We're providing a safety plan intervention. We're addressing every social need that we kind of come across. So that way it kind of reduces a re-encounter back to the ER. And overall, it provides a lot of consistency in being able to communicate across all disciplines. But like Ms. Diann said, we're able to see electronic charting, we're able to see each other's notes, and we're able to kind of follow along and see how the patient has progressed, things of that nature.
Diann, from your perspective, what are some of the key lessons you learned and some advice you'd pass on to those who are hoping to do this work in their own organizations?
Yes. And I would say in addition to buy-in is that you just can't over-communicate the process. I think it would be helpful to identify champions at each site. Like in our system, we have nurses who are doing the initial screening. So to have a nurse champion to just make sure that the flow is working. I think sometimes it's a challenge because the nursing staff, at least in our setting, there's so many different tools that they're using at intake, so many different flow sheets. And so here's another flow sheet. So really trying to get them to understand the importance of it. It's not just another something that you check off. How important it is to make sure that the verbiage is the same as it is on the document so that what was intended comes across to the patient. And again, that can be very challenging when you're in patient care and you're trying to get the patient through intake to get them to their PCP. I think the other thing is really just having patience and having some grace because it does take a while to get acclimated to a new process. You know, you're talking about suicide risk, which can provoke anxiety not only for the patient, but also for the staff in terms of asking the questions. So helping the staff to develop some comfort level in terms of asking the questions and knowing that if it is positive or even if they still have some concerns, but it doesn't meet the threshold of social work referral, that they can still reach out to the social worker to get some assistance as needed. And I think the other thing also, finally, just to be prepared for any type of IT glitches that might happen.
I think that's good advice for everything in life. Be prepared for the glitches that may come. Thank you, Diann and Jenny, for your time today, for really giving us an inside glimpse on how this works, incorporating the social work team on behavioral health. And I encourage everyone listening to also access the webinar that the Parkland team is recording for us that'll be available on our website on aha.org that'll go in depth into their process across all of these settings. Again, Jenny and Diann, thank you for your time. Really appreciate the work that you do.
Thank you. Thank you so much.